Now, we, as far as modern era is concerned, almost in every lab we these days have cell counters, and these cell counters, they are uh, responsible for a lot of diagnostic work being done, and everybody is seeing histograms. But somehow the potential of these histograms has not been achieved completely. So we'll try to solve some problems. Now, histograms are basically graphic representation of the cell frequencies versus size, and they provide information about the erythrocytes, leukocytes, platelets, their frequency and distribution, as well as presence of any subpopulations. Shift in one direction of or another can be of diagnostic importance. Now, it is important that these histograms, we need to correlate them with the normal, with the whatever disease we are seeing otherwise, and so that over a period of time we become very confident about our interpretation of these diagnoses. They are not replacement of the actual naked eye interpretation, but they provide a flag or direction. They help us move in a certain direction. They are produced by millions of signals passing through a small detector, where they are differentiated by size and frequency and occurrence in population. We usually have three-part differentials, which have granulocytes, lymphocytes, and monocytes. And five-part differentials, they tell us about, they divide the granulocytes into neutrophils, eosinophils, basophils, lymphocytes, and monocytes. The monocytes are usually in the middle. A sixth category, which is the large unstable cells, they are included. They are larger than normal, and they don't have any peroxidase activity. They could be abnormal lymphocytes or other abnormal cells. Some modern cell counters, they also have the flagging for large immature cells composed of blasts and immature granulocytes and atypical lymphocytes, and which include the blast cells. The hematologic analyzers, they provide the mathematical results obtained by electrical and light signals generated when the cell passes through a sensing zone of the machine. And two methods are there. One is the electrical impedance counting, and the other is the light scatter method. Now, what happens that there is a small aperture through which light passes, light or through which the cell passes, and each cell, it has a certain resistance. This electrical resistance is according to Ohm's law, E is equal to IR, and this resistance produces an oscillation in the galvanometer. The amount of oscillation produced could be in thousands or millions, depending upon Wbc or Rbc are passing, and the frequency and the amplitude of the oscillation is noted, and which is passed through a computer to generate a histogram. In the light scatter method, a light is passed through the cells on the cells, and which are scattered, and this causes the cells to be produced a certain photovoltaic cell is there, which produces an electrical impulse. Now, if we see, there is a dilution of the blood, which is basically for hemoglobin, uh, it is always the Drapton solution, and also otherwise there are some other diluents for Wbc which remove the RBCs and there is a vacuum pump which pushes this entire blood and the diluted blood, and there is an electrical impedance method, impedance apparatus, and there is a reagent which which helps in lysing the RBC or diluting the cells so that they pass in a single file. See, RBCs, they pass through two electrical impulses, and they produce an impulse on the oscilloscope. Similarly, the neutrophils, WBCs, lymphocytes and monocytes, they all produce an impulse. But if you see the impulse which is produced by the neutrophils is is at a different place. The monocytes is different, and lymphocytes is at a different amplitude. We'll just see. And before various WBCs, they swell up after the lysing reagent is placed on them, and neutrophils, which are 10 to 15 micrometers, they swell up to 120 to 250 femtoliters after placing the lysing reagent. The basophils, which are 9 to 14 in size, they are red at the level of 70 to 130 femtoliters. Eosinophils, which are normally sized as 11 to 15 micrometers, they increase their size to 80 to 140. The monocytes, which are 12 to 20, they increased their size to 60 to 120, and lymphocytes, which are normally sized 7 to 12 micrometers, their size becomes 30 to 80 femtoliters. Now, platelets, which have a volume of 8 to 12 femtoliters, are counted at 2 to 30 femtoliters. The RBC with the volume of 80 to 100 femtoliters, they are detected at the range of 30 to 250 femtoliters, depending upon their size and whether it is microcytic or macrocytic RBCs. While counting WBCs, the RBCs are lysed by a lytic reagent, and different WBC discriminators are set at different levels between the ranges of 30 to 450 femtoliters. So a normal histogram has three parts differentials for white cells. The 30 to 125 micron range is for lymphocytes, 25 to 160 for monocytes, and 60 to 450 micron range is for granulocytes. So they are read at the different areas of the histogram. So see this, now this is the WBC histogram. If you see, because the neutrophils, they are of maximum size, they are read at here at 250, around between 250 and 350 femtoliter. The monocytes in the middle and the lymphocytes on the extreme left. The extreme right is for neutrophils. Monocytes are in the middle. Monocytes and even eosinophils, they are in the middle. And in those cell counters which give the 5-part histogram, again the neutrophils are at extreme right. The eosinophils are slightly on the middle, eosinophils and monocytes, and also the basophils. The lymphocytes are on the extreme left. This is another picture depicting the same. Now the normal RBC histogram, you see the normal RBC, the size is median is 80 to 100, with the median coming around 90. Now this is the normal size of the histogram, and this is the amount of anisocytosis. Any shift to right or left, or the amount of anisocytosis, will lead to a change. Now let's see some histograms. Now in this histogram, RBC histogram, we can see that though this there is the peak is still around in the middle around 90, but there is a big disturbance due to this is usually seen in cold agglutinins when the RBCs they stick to each other and they form some broken particles. Now in this one you see that the width of the histogram has increased, and this is seen in the macrocytosis or target cells seen in thalassemia. Now here if you see that the absolute zero is not there, but it is starting from the top, slightly above zero. This is when some particles are there, and small particles. This could be seen in hemolytic anemias, giant platelets, or microcytic very small broken RBCs. And here if you see that there are two dual peaks. Dual peak is seen in case of dimorphic anemias, the patients who have taken the blood transfusion or they have taken some kind of taking treatment after iron deficiency anemia. Now this is a normal platelet histogram. You can see it is around, the peak is around 6 to 8 microns, and in case of the giant platelets the size of the histogram swells up, and or in smaller platelets the peak shifts to the left. So let us see some WBC histograms. In the first one you see that on extreme right there is increase when there is lot of waviness. This is immature neutrophils. In case of lymphocytosis there is a peak on the extreme left, and when there are band forms in neutrophils, again in this case there is a peak on the extreme right. In eosinophilia there are immature neutrophils. Here you can see that there is a peak in the middle as well as on the right. When there are some blast cells, there is a peak in the middle. In adults the WBC count is around 4,000 to 11,000, and in children it is 12,000, and newborns it is still higher, that is 15,000 or even 18,000. The lymphocytes in adults are 25 to 40%, while in newborns usually it is there are more lymphocytes, and this is gradually changes around 6 months, 6 to 8 months, or even 1 year. The ratio reverses. In the adults there is a mixed cell population comprising of eosinophils and monocytes, and basophils around 3 to 13%, and in neutrophils are 50 to 70% in adults. The RBC count is, as we all know, is for men is 4.6 to 6 million, or you can take some slightly lower than it is also 3.5 to 5 million, whereas in females it is lower. The hemoglobin is 14 to 18 grams per deciliter in men. In women it is 12 to 16 grams. The hematocrit is 43 to 49%, while it is lower, around 36 to 46% in women. All these parameters, they are important when flags are generated. The mean corpuscular volume of 85 to 95 femtoliters. MCH is 27 to 33 picograms, and MCHC is 32 to 36 grams per deciliter. The red cell distribution width is 37 to 46 femtoliters. There is something known as red cell distribution SD, which was a question asked. The width, that is the width is in the 20% of the peak height, and the red cell distribution width of CV is 11 to 16, that is coefficient of, according to coefficient of variation. The width is at 60% of the peak height. Exact significance of these is both are equal. I'm not sure about this. The platelet count is normally 150 to 400, and platelet distribution width is 9 to 14 femtoliters, and mean platelet volume is 8 to 12 femtoliters. Now let us take a case of iron deficiency anemia. In this case, this reddish part is the normal, and in case of early iron deficiency anemia, the peak shifts and the anisocytosis starts increasing gradually. Change in anisocytosis is the first change, though the peak may not shift too much in the beginning. Increase in the RDW, this is the earliest sign of early iron deficiency anemia. In case of advanced iron deficiency anemia, the peak shifts and there is abnormally high this RDW, which means if we compare it with the normal, which is the red one, the entire peak shifts to the left. As the patient starts recovering from iron deficiency anemia on giving iron, we see a dual population. So a peak starts appearing here, additional peak. So we have one this peak and one this. On the left side, on the right side, it is the higher size, bigger sized RBC start getting produced. In early folate deficiency, the mean corpuscular volume is still that of normal RBC, but the RBCs they start getting reduced in size, and the RDW is gradually increased. And in severe folate deficiency, if you see, there is hypersegmentation of polymorphs, but in histograms, the peak shifts to the right, and the RDW also gradually starts increasing. The platelet distribution width also starts increasing. And once we start giving the treatment for megaloblastic anemia, a new peak starts appearing here. And also here in iron deficiency anemia, another new peak starts appearing in the histogram, which represents a recovery population. A dual population of cells is there. Now this is another case of a 12-year-old boy with purpura and marked pallor and along with fever. There is pancytopenia. The mean corpuscular volume is 100.5. The red cell distribution width is 15.9. You can see this is a case of megaloblastic anemia, and the RBC count histogram has shifted towards the right. The Wbc histogram, there is a dome of the lymphocytes are there, but the neutrophils, they are suppressed. In the platelet histogram, there is, you can see a lot of broken RBCs, or these disturbances are there. These are generally due to in case of and overall in this case the Wbc count is markedly decreased. So if we see that this broken slopes, they are basically broken RBC, small particles, and overall this is a case of aplastic anemia. The MCV, though it is raised, the red cell distribution width is, there is a shift is also increased, but the total number of the count is reduced. Now this is another case. You can see the Wbc area, there is a huge peak, and we can see that there is lymphocytosis. There is neutrophilia. This is the neutrophilic area. This is small in between is the mixed cell population, there is monocytosis, and this is for the lymphocyte. So this peak on the extreme right, it represents neutrophilia. This is the blood picture in which we find lot of neutrophils. Now this is another case in which there is peak on the left side, that is lymphocytosis. Another histogram, that is the mixed cell population is above normal and lymphocyte count is markedly decreased. Overall Wbc count is also lowered. So this is the picture. that in the middle the histogram is raised, that is monocytosis, or there could be sometimes eosinophilia. Now this is another case in which there is eosinophilia. In eosinophilia also the middle peak is raised, neither the lymphocyte area nor the neutrophil area. Another case in which, now here if you see that there are lot of nucleated RBCs and there is a dual. Now such peaks, they have to be checked, and histogram shows problems. There is the rise in the histogram is on the left side. This is another case in which the count, WBC count, is markedly reduced, and there is increased in the mixed cell population, and also you see that at the extreme right there is, it doesn't reach zero. This is sometimes seen in case of when the cells, there is some autoimmune disorders, or there are giant particles, sometimes they create such pictures. Next case is when the RBC count is normal, the hemoglobin is 8.8 and hematocrit is 29.3. Mean corpuscular volume is markedly reduced, and the cell distribution width CV is 18.2. In this case, if you see that there will be the platelet histogram is raised. This is the RBCs, they show they are of a normal type, but we will get giant platelets. Another case where the hemoglobin is 6.2 but MCV is markedly increased. This is seen in case of, if you see, and there are a lot of RBC histograms, it shows additional peak. This shows peak in the neutrophilic area, and in the RBC histogram, which is below, the peak is shifted beyond 100. This is megaloblastic anemia, and these giant neutrophils, they are hypersegmented neutrophils or large neutrophils. Another case in which we have the RBC count is normal, hemoglobin is also normal, but an MCV is also increased, and RDW, red cell distribution width, is increased, that is marked anisocytosis. This is the anisocytosis increased. This is usually seen in iron deficiency anemias or megaloblastic anemias. Another case in which the red cell distribution width or anisocytosis is increased. This is when there is marked poikilocytosis, and along with poikilocytosis sometimes there are the clumping of platelets is also there along with poikilocytosis. So the platelet histogram is doesn't touch zero. Another case in which the platelet count is markedly so when there are giant platelets, the platelet histogram doesn't touch zero. So there is wide distribution of platelet histograms. They may become abnormal once there is any kind of giant platelets, clumping of platelets, some autoimmune disorders. These flags, they get generated. Another case in which the platelet count is markedly decreased, and we are in the RBC, in the histogram, this doesn't touch zero, and because there is the giant platelets, they cause disturbances, and even in WBC histogram as well as RBC histograms, we sometimes find such disturbances. Now the platelet aggregation is disturbs the WBC histogram, creating a ghost area as in this one, and sometimes the platelets, they clump and creating an alarm. Then sometimes in case of thalassemia, or not only thalassemia, or even in cold agglutinins, in cold agglutinins, what happens that the RBCs, they clump with each other and they form large large size clumps, and they form abnormal peaks along the entire histogram. Quite often we are called in the middle of the night from blood banks, and in these cold agglutinins, especially in North India, they are a big culprit for calls in middle of the night. The technician says that almost all the cells, the blood group cannot be found out. Even it is coming positive with A, B, AB, everyone, and a slight heating of the slide solves the problem. We just incubate the slide for 30 minutes and the RBC count comes to normal. This is the same slide. The RBCs have separated by just half an hour of incubation. So in this case, the RBCs, they pass through the detector as clusters of several cells. The RBC count, the hematocrit, MCH, MCV, they are all abnormal. And the Rbc histograms, they show second peaks, as in this case. Then sometimes the Wbc count appears very large with no clear-cut evidence of lymphocytes, mixed cells, or neutrophils. This is the insufficient lysing of erythrocytes is sometimes there, and these erythrocytes they give false flags in the Wbc histograms. So sometimes the samples taken from the patients of hepatic disease, or sometimes we are those having high protein levels. Sometimes if we just replace the plasma with our cell pack, which is provided along with the sample, it helps in clearing the proteins, and the counts, they start they can be counted. So in case of CML, sometimes we get because the count is very high, we get a dome shaped curve without any, which doesn't touch the baseline. There are a number of flags which come up. That is the abnormal heights of the lower discriminator in the Rbc histogram, or the abnormal height of the upper discriminator, which comes in case of anemias, or multiple peaks between in dimorphic anemias, or the various red cell distribution widths. They cannot be detected because they cross the 20% limits twice, or even more than that. WL is the abnormal height of the lower discriminator, sometimes becomes disturbed. One flag is the generated due to giant platelets, microerythrocytes, or platelet clumps. They form the abnormal lower discriminators. Or cold agglutinins, they cause the abnormal height at the upper discriminator, or the erythroblasts and normoblasts, they all form the abnormal height of the upper discriminator. Malarial parasite causes multiple peaks, and along with that there could be iron deficiency in therapy, or blood transfusion. They all cause multiple peaks. The dimorphic anemia, as a result of giving to an iron deficiency patient, this also causes problems. Then the abnormal distribution curve of the histogram, this also causes extreme anisocytosis or poikilocytosis. And if the overall height of the curve is normally taken as 100%, and if the 20% of the height of the curve is from where the width is calculated. Then in platelet histograms, the reference range is 8 to 12 femtoliters, and the ratio of large platelets is around 15 to 35%, and increase could be a sign of platelet clumps, giant platelets, or sometimes our broken RBCs, they also look like platelets. The platelet distribution width is another parameter which is we are getting a lot of papers available, and the normal reference range is 9 to 14 femtoliters, and their increase in number could be a sign of platelet clumps, microerythrocytes, or fragments. And the abnormal height of the lower discriminator could be because of the broken RBCs or high blank values in case of the platelet discriminators. And sometimes abnormal height of the upper discriminator in platelets could be because of platelet clumps, EDTA incompatibility, giant platelets, and microerythrocytes. Multiple peaks could be because of platelet transfusions in platelet curves, and the distribution width, if it is more than 20%, causes the histogram to become very abnormal, and there are a lot of disturbances are seen. In leukocyte histograms, we have got, we get two troughs, T1 and T2, and sometimes the curve this does not begin at the baseline, and this could be due to platelet clumps or EDTA compatibility or high osmotic resistance, or when the RBCs are not broken due to the lysing agent or cold agglutinins or presence of erythroblasts, nucleated RBCs. So basically, the various possibilities could be that of abnormal indicators are that the left of the curve does not touch the baseline. It could be because of schistocytes, broken RBCs, and we should review the smear and platelet histogram. A bimodal peak represents the transfused cells or some therapeutic smear, or even giving the therapeutic response to RBC or vitamins. Sometimes the right portion of the curve is extended in case of red cell autoagglutination, and we should review the complete blood count. If the curve is shifted towards the left, it could be microcytes. If the shift is towards the right, it could be macrocytes or megaloblastic anemia. Then in Wbc histograms, if the trail is extending downwards towards the extreme left, or the lymphocyte peak is not starting at the baseline, it could be nucleated RBCs or platelet clumping or analyzed RBCs or proteins, parasites. We should review the WBC, review this slide for nucleated RBC. If the peak to the left is of the lymphocyte peak is widening, or there is widening of peak towards the left, it could be nucleated RBCs, and we should review the slide. If the peak is markedly widened, then we could have atypical lymphocytes, blast cells, plasma cells, hairy cells, eosinophils, and basophils. The wider monocytes could be because of monocytosis, plasma cells, eosinophils, basophilia. Histograms, the WBC histograms, if they don't start at the baseline, you can see the giant platelets or nucleated RBCs. Or in all these, we should review the smear. If the elevation of the left portion of the granulocytes is there, then there is shift to left, which could be because of monocytes or eosinophils. If the elevation of the right portion of the granulocyte peak is there, then it is marked neutrophilia. In the platelet histograms, if the peak is on the left end of the histogram, it could be broken fragments of RBC or platelets. If the peak is towards the right end of the histogram, it could be again schistocytes, microcytes, giant platelets, and we should review this smear and do the complete blood count again even with naked eye. It could be because of decreased mean corpuscular volume and increased RDW. A bimodal peak represents cytoplasmic fragments. So we get in the RBC, the various flags, they could be RBC precursors, giant platelets or clumped platelets or cryoglobulins or basophilia, eosinophilia, all these plasma cells or abnormal lymphocytes, they produce the flags. And in the eosinophilia and immature granulocytes, they also produce in the middle of the WBC curve, they produce certain peaks. And absolute granulocytosis, they also produce peaks. This R1, R2, R3, R4, they are the flags generally created by the cell counters. So in conclusion, histogram in conjunction with absolute counts gives the valuable information about the sample. However, the manual film remains the definitive tool for complete hematological analysis. There is nothing which can replace the manual examination with the human eye. Thank you very much.